want you to pick it up. So the next objective is list and interpret critical investigations, including electrocardiograms, chest radiographs, appropriate laboratory tests, and identify as appropriate patients for additional investigations like stress testing. If you remember, we learned that one of the categories of patients who need further investigations are those who come in with chest pain. We do, and we suspect that this is acute coronary syndrome. We do our initial ECG, nothing. We repeat the ECG after 15 to 30 minutes, nothing. We keep the patients in the emergency room for 6 to 12 hours. We repeat the ECG, nothing happens again. Those patients, I want to get them to see a cardiologist for a stress test. So now, let's get in. What to do for a critically ill patient with chest pain? What to do for a critically ill patient with chest pain? Learn this algorithm very, very well. And if you forget everything, don't forget this particular algorithm. Number one, patient presents with chest pain. I do my ABCs. The next thing, I quickly listen to their chests. If the patient presents with chest pain with absent breath sounds, especially in the context of a patient who had trauma, that is tension pneumothorax until proven otherwise. I'm going to put in my needle to decompress the chest. So acute chest pain, I listen, I can't hear any breath sounds. I'm not going to waste time at all. Tension pneumo. Acute chest pain, the patient has absent, there are no absent breath sounds, like you can hear breath sounds. So I'm not thinking about tension pneumo. I go on to do my ECG. My ECG is done. And I also do my chest x-ray. And my ECG is positive with ST segment elevation. And maybe the chest x-ray shows some pulmonary edema. My next diagnosis is acute coronary syndrome. So chest pain, you can hear breath sounds. You do your ECG. ECG is positive. The patient may have some crackles and some rails. ECG with ST segment elevation in specific leads, not diffused, in specific leads. I'm thinking about acute coronary syndrome. And then I can bring it down, whether it is anterior MI, lateral MI, inferior MI, anterolateral MI, posterior MI. Next one, chest pain. I can hear breath sounds. I do my ECG. ECG is not very specific. But then when I do a chest x-ray, I see that there's widening of the mediastinum. My diagnosis is thoracic aortic aneurysm. Wide mediastinum, chest pain. When I listen to the chest, I can hear breath sounds, thoracic aortic aneurysm. Next one, I do my ECG. The patient presents with chest pain. I listen to the lungs. I can hear breath sounds. The ECG is negative for ST segment elevation. But when I do my chest x-ray, I see subcutaneous emphysema. It looks like there's air under the skin of around the rib cage. And I see some mediastinal air fluid levels. My diagnosis, esophageal rupture. Next one, the patient has chest pain. I can listen to the lungs and I can hear breath sounds. I request an ECG. The ECG is positive for, maybe some ST segment elevation, but then I see what we call a right ventricular strain pattern. Chest x-ray, I may not really see anything significant. What is my diagnosis? Pulmonary embolism. So doctors, when you get the replay of this video especially, pay attention to this, because I've dropped a lot of gems, a lot of words, which you need to watch out for when you're preparing for your board exam, because that is what will help you to differentiate between acute coronary syndrome, aortic aneurysm, which will show widening mediastinum, esophageal rupture, which will show subcutaneous emphysema on x-ray, and pulmonary embolism. So if I have a patient who has chest pain, what are the investigations I'm going to request for? First, ECG. That one, no-brainer. ECG. Take blood for troponin levels as well. You can request a bedside chest x-ray. You can do bedside lung and cardiac ultrasound as well. You can check your blood pressure in both arms, because if there's aortic dissection, blood pressure will be elevated in one arm and it may be low in the other arm. You may want to do your CBC, your renal function test, your liver function test. You've already talked about your cardiac biomarkers. But if a patient has chest pain, ECG, cardiac biomarkers, chest x-ray, boom, 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 boom. CBC, renal function test, and liver function test, they can go down your pecking order. You can do your bedside abdominal ultrasound, because we've learned that there are some GI causes of chest pain as well. You can do your liver enzymes and liver function test. You can then do your lipase, because we learned that pancreatitis can also present with quasi chest pain. All right. You can do your VBG with your lactate, your ABG, and you can calculate your AA gradient as well for this particular patient. And then you can do your D-dimer, because we learned that pulmonary embolism can also cause chest pain. If the patient is a female, you want to do your beta HCG. You want to do your urinalysis, urine culture, urine for sensitivity. Then you can consider CT angiogram and CTPE. But all these are all dependent, especially those on the right. The ones on the left, your ECG, your chest x-ray, your cardiac biomarkers, you should not waste time on them at all. You should go for them, because those ones are very, very critical. All right? Okay, good. Now, while we are breaking all these things down, I want to keep going back, because I want to make sure that we are getting the concepts right. So, if you have a patient with chest pain, you do your ECG or your EKG, and you see some changes, ST segment elevation, start thinking about acute myocardial infarction, start thinking about aortic dissection. So this is also a learning point, that it's not only acute myocardial infarction which causes ST segment elevation on ECG. The aortic dissection can also do that. In fact, pericarditis can also cause ST segment elevation on ECG. But the unique thing about pericarditis, and please listen, is that the ECG changes and ST segment elevation in ECG on pericarditis is diffused. It is in almost all the leads. All right. We also learned today that if you have a patient with chest pain and you do your ECG and you see a right ventricular strain pattern, right ventricular strain pattern, right ventricular strain pattern, think about pulmonary embolism. If you have a patient with chest pain, you do your ECG and there's diffuse ST segment elevation, diffuse, it is in all the leads. Think about pericarditis. You have a patient with chest pain, and you realize that the patient has a mediastinal shift. Maybe you palpate the trachea, it's moved. Think about tension pneumothorax, and you also see that on chest x-ray. You also have a patient with chest pain, you see a wide mediastinum. We've already talked about this. This is only re-emphasizing what we've learned. Think about aortic dissection, chest x-ray with effusion in a patient who probably had a motor vehicle accident. Think about esophageal rupture. You do a chest x-ray in a patient with chest pain again, and you see that the cardiac contour looks big, and it looks like, a ball around it. Think about pericarditis, which has been complicated with some pericardial effusion. You do your chest x-ray in a patient with chest pain, and you notice pneumomediastinum. Pneumomediastinum. Think about esophageal rupture and mediastinitis. I have a question. What is one unique thing on history that will point to esophageal rupture? I said it in the previous slide, but I just want to re-emphasize it. What is one thing you will pick up on history that will help you to think that this is esophageal rupture? Yes, please.
Subcutaneous air.
Forceful vomiting.
Forceful vomiting. Beautiful. Forceful vomiting. So the patient developed chest pain and was trying to vomit. Okay. So chest pain, you do your ABGs, the patient has hypoxemia, AA gradient, abnormality. Think about pulmonary embolism. Chest pain, you do your spiral CT. That's also pulmonary embolism as well. So doctors, I hope this helps. Now, if you do your ECG, and these are points we've made. but I'm going back over and over and over again. If you do your ECG, what will you see on classic MI? You see ST segment elevation in some unique leads. If it's inferior MI in lead 2, lead 3, and AVF. If it's anterior MI in lead V1 to V4, okay? Now, if there's subendocardial infarction, this is why you don't need to know all these details. If I were you, I will learn the top one, and I will learn the last one. ST segment elevation, classic MI, in unique leads. ST segment elevation, which is diffused pericarditis.